Well, it's nice to meet you all. I'm Alex. I'm one of the IRs here. I'll be talking about thyroid ablation. Just a show of hands, how many of you guys do thyroid ablation here? Any interest? Okay, good, great. So it's good to see somebody else here. It's at this point it's definitely a shared practice amongst ENTs and head and neck surgeons. So I'm glad that there's at least some interest to do thyroid ablation. I can only see this service line growing. So what I'm going to present today is truly a small kind of a small slice of the pie, so to speak. There's a lot more to discuss and a lot more coming up, especially in the malignant space. But nonetheless, I'll try to do this topic justice. And with that, we'll get going here. I have no disclosures. The objectives today are to discuss the role of ablation for benign nodules primarily. Okay, we'll briefly review the data, review the technique and the follow-up, and of course present a few cases. Okay, and I'll try to do this all within the 20-minute time limit that we have. Just a bit of background. Benign thyroid nodules are very common, up to 80% of the population. And the vast majority of these nodules are benign. Okay, although benign, thyroid nodules can be felt and seen when they become large. And RFA is a minimally invasive technique to treat benign nodules that are symptomatic. This is important because, as being so common, it's a large swath of the population that's maybe coming to your clinic or to your office for this procedure. So I think it's good to get ahead of the curve, so to speak. So how it's performed, for those who are unfamiliar, it's the moving shot technique that was kind of described initially in Korea and has been, made its way to Europe and now to the US. This is a picture from the literature, and it's via trans-isthmus approach. So we access through the isthmus into the nodule. We kind of park our ablation probe within the nodule, first in the far field. We start the ablation, start the generator, and then pull back while we see the microbubbles form towards the near field. And then we move the probe, usually more laterally, and then kind of proceed that way. And then every time we move the needle, it's an ablation unit, so to speak. And there are a few methods of ablation. Okay, there's chemical, which is more of the ethanol ablation. It's more classic. And then thermal ablation. That's further separated into microwave, RFA, and laser. I prefer RFA. There are some studies that compared microwave with RFA, and the limited studies that have been performed show that microwave has been associated with a less durable response, so higher rate of regrowth, even though the microwave ablation does tend to get a little hotter. With that limited data, I do prefer to stick with RFA. I don't really have much of a reason to go with microwave. So in terms of indications, any symptomatic nodule, so symptoms being airway compromise, difficulty swallowing, pain or pressure, is an indication to perform the procedure in patients who, for other reasons, are not interested in surgery or just not good candidates for surgery. Okay, solely cosmetic concerns are possible. I see patients, probably a third of the patients that I see are for cosmetic reasons. They just don't like how it looks, and that's perfectly reasonable as well. Insurance coverage may be a little more challenging for patients who don't have any symptoms. Toxic nodules, AFTNs, are also a good indication for this procedure. The classic treatment is either radioactive iodine treatment or medical management. Okay, compared to RAI. RFA is ideal for patients who don't want to isolate for any reason. Maybe they have kids, maybe they have work, who like to avoid radiation, or concerned about the side effects, the dry mouth, things like that. Okay. In terms of nodules, okay, so 2 to 3 centimeters in diameter is the ideal nodule size. Less than 20 cc's in volume are those nodules which I can reasonably get with a single session. Okay, for larger nodules, RFA can be used with the understanding that multiple sessions can be needed. And always have this discussion in clinic. If it's greater than 20 cc's, I tell them, hey, look, I can probably maybe get it in one, depending on how well you tolerate the sedation and laying flat for an hour or so, but it may need a couple more treatments. For multinodular goiter, for diffusely enlarged nodules, I offer embolization. So transarterial embolization can be done with bilateral radial access. You can treat the inferior thyroid artery, but again, that's something that is usually when they come to see me, they've read about thyroid RFA. They kind of want that in their mind. They have that in their mind, and they kind of want it done. Maybe one patient had embolization. It's not really a large part of my practice just yet. Complete visualization under ultrasound is necessary. Obviously, if you can't see it, you can't treat it. And it needs to be benign, but that's the two nodules. Okay. How to manage indeterminate nodules with benign molecular profiling is still kind of up in the air, still kind of unclear. It's not a I don't treat those patients just after having a discussion with our endocrinologist and our ENT surgeons or head and neck surgeons. That was the decision that we came up together, is to not treat those patients. And then in terms of AFTNs, usually less than 12 cc's is what I like to see, primarily because there's a study that showed that patients who have AFTNs less than 12 cc's in size tend to respond much better. Response being normalization of their thyroid hormones, 80% versus 45%, with respect to those patients having greater than 12 cc's and less than 12 cc's in size. A few contraindications. So pregnancy and presence of a pacemaker, those are essentially absolute contraindications when you're using a monopolar system. I guess you can use a bipolar system and find ways around it, but at this point, it's not, I wouldn't really recommend treating pregnant patients or those with pacemakers with a radiofrequency probe. Relative contraindications include malignancy. Again, put a star there because there are some new studies that show that you can perform ablation for T1A and T1B well-differentiated thyroid cancers. Again, I recommend having a group discussion with your neighborhood endocrinologist or your ENT surgeon or your head and neck surgeon before kind of embarking on that. Cystic nodules respond better to ethanol ablation. It's cheaper, and in some studies, at least as effective, if not more effective, than radiofrequency. Pre-existing contralateral vocal cord palsy, you have to be very concerned that if you somehow box the recurrent laryngeal nerve, that's with your ablation, that you may, not have any might really worsen their hoarseness. Large substernal subclavicular nodules, if you can't see it, you can't treat it. And dense calcifications similarly. If calcifications are obscuring your ultrasound, you shouldn't really be ablating blind for obvious reasons. Just briefly, this is again a small sliver of all the studies that have been shown that have been used to describe RFA. So the volume reductions I'll tell patients somewhere between 60 to 80% at 6 and 12 months. Okay, the first 6 months are when the most rapid volume reduction occurs, but still occurs after 6 months. After 12 months, it kind of slows down significantly. There is significant quality of life improvement on these quality of life scales. Okay, and there's no significant impact on outcomes or safety of future thyroidectomy after RFA. A lot of patients have that concern that, if it grows back, can I still get an RFA? And I've spoken to surgeons in the past who've operated on a post-RFA bed, so to speak, and it's fine. It's a little scar tissue, but it's doable. It's doable. Some limited comparative data exists comparing surgery to RFA, and as you can imagine, RFA results in greater patient satisfaction, better quality of life, fewer complications, shorter hospital stay, lower incidence of hyperthyroidism requiring supplementation, and lower cost. And RFA is associated with a slower size reduction compared to surgery, as well as a theoretical high risk of recurrence. Obviously, if you're removing the thyroid gland, ends up in a bucket, you can't really get thyroid nodules, recurrence, so to speak. And and this is the main reason why I think RFA is going to be kind of a big part of everyone's practice, is because it is such a great alternative